All right, welcome. We will be reviewing the use of botulinum toxin for cervical dystonia. I would like to dedicate the talk to the memory of my father who wanted me to be an educator. We will be discussing essential features of different subtypes of cervical dystonia or positions and common muscles involved. I will explain basics of injection planning for different subtypes of cervical dystonia, and we will quickly touch on common techniques of injections for cervical dystonia through some videos. So let's give a clinical context. Sarah, a 60-year-old presenting with pulling and tightness in the neck. She had it for more than 10 years, but recently has gotten worse. She reports difficulty keeping her head straight for the pictures and some pulling of the head to the right. Admits to slight pain in the right side of the neck. She has tried and failed levodopa, clonazepam, and baclofen. So, what would you tell her about the benefits of shot? How likely it is to help or not? What muscles would you inject and how much you will inject? It's a most common form of a focal dystonia. It's about 200,000 prevalence. Head tremor or jerking of the head is seen in 60 to 70% of the patients, not everyone. Neck pain is seen in 65 to 75% of the patient. Not everyone, but significant number. Now, here's a useful tip to remember. Cervical dystonia is the only dystonia which has an associated pain routinely with it. Most dystonias are painless, almost all, except for cervical dystonia. And cervical dystonia may remain isolated, which is common, but in 23%, so one in five patient, they can have a spread of dystonia, can go to the face, lower face, upper face, can go to the shoulders, can go to the back, hand can be involved, but in 80% it remains focal. Here's a useful tip to remember. An isolated head tremor is cervical dystonia until proven otherwise. Normally, with head tremors, we think of essential tremor, but in essential tremor, if the head tremor does not go to the hands after 3 years, is considered an exclusion criteria. But I would venture to say that even before 3 years, if you're seeing just an isolated head tremor, there is no arm or leg tremor involved, then you should first think of cervical dystonia, which is the most common cause of an isolated head tremor. Usually, the head tremor is jerky, shaky, and may have a directional component. So, it may have a direction to one side where the dystonia is pulling the head. It's a clinical diagnosis. There is no validated diagnostic criteria, no validated comprehensive rating scale for cervical dystonia. There are some scales we use, such as SWE rating scale and twisters, but they are not comprehensive and they're not validated. And 88% of the patient, or almost 9 out of 10, may have a sensory trick. So, sensory trick is that a simple sensation can counteract the dystonic posturing. So, let's say someone is getting a pulling and jerking to one side, and sometimes just touching the chin may help them calm the head down and be able to look straight. And if they let go, then the head may pull back and they may start having jerking again. Sorry, with all these head positionings that I'm showing, I'm moving away from microphone, so my voice may fluctuate a little bit. I apologize for that. Botulinum toxin injection or chemodenervation with Botox like toxins is first line treatment for cervical dystonia as per the American Academy of Neurology guidelines. Although we sometimes see benefit with some other medication, the benefit is weak and uncommon, 20 to 30% of the patient, and usually less than 50% improvement. You can have a remarkable improvement with botulinum toxin. So that is the best approach. This picture, by the way, that I've showed a couple of times is actually the marble bust of Alexander. And Alexander was shown always with the head tilt in his images or in his bust. And most people think that it's probably because he had cervical dystonia from repeated neck injuries. Neck injury and head injury, but especially neck injury, is considered a high risk factor for developing cervical dystonia. Not a direct cause, something we think just makes it more likely for the brain to get it. There are 8 class 1 studies of botulinum toxin establishing it as safe and effective for the treatment of cervical dystonia with a level A evidence for all 4 toxin products. So the best studied indication for botulinum toxin injections. The only exception will be pure enterocollis or neck flexion downward, which is the most common abnormal neck posture associated with Parkinson's disease and is almost always excluded from cervical dystonia trial. There is a debate if it responds to botulinum toxin or not. I do think in selected patients it does help, but you have to have a clear evidence that there is a dystonia in the neck. Most often, enterocollis may be because of a neck extensor myopathy in Parkinson's patient where they have weakness on the back of the head, and that may be present in combination. So you want to see if they can lift their head up against resistance or not, and you want to palpate and check their neck. When you examine if a patient has a dystonia in the neck, as they try to look up, the normal person's the neck muscles, anterior muscles will relax, while in a dystonic patient, the SCM will become more tight and spasmodic as they try to look up on their own. So things you can do an examination to try to see if they have a true dystonia or not in enterocollis. But in general, the data is not very clear. So there is one class 1 trial of ANA botulinum toxin A, which is Botox, 2 class 1 trials of ABO botulinum toxin A, which is Dysport, 3 class 1 trials of RIMA botulinum toxin B, which is Myoblock, and then 1 class 1 study comparing the Dysport with trihexyphenidyl, and 1 placebo-controlled class 1 study of INCO botulinum toxin A, which is Xeomin. So all the drugs, toxin, work very effectively. So in ABO botulinum toxin A or Dysport studies, the doses have been 250, 500, or 1000 unit with a range usually of 260 to 290 units. And there was more than 50% improvement with number needed to treat was only 2 with 1000 unit or 3 at 500 units. So, more benefit at higher doses, but then you have more risk of side effects. The example, the scale they looked at for mean improvement was Twisters or Toronto Western Spasmodic Torticollis Rating Scale, and the improvement was 9.9 points, almost 10 points, and number needed to treat for more than 30% improvement was 5 patients needed to treat. So that may have been a low dose study. RIMA botulinum toxin B or Myoblock, usually not the first line treatment for us. We typically go for Myoblock if we have resistance or failure to type A toxin. The dose is typically 2,500 all the way to 10,000 units. Number needed to treat is 2 for more than 20% improvement in Twisters. Twisters improvement is 9.3 with 5,000 unit and 11.7 with 10,000 unit. Number needed to treat for all studies is 8 and is for 10,000 unit is 3, but then they have a lot more dry mouth, almost 30% of the patient. Number needed for treatment for dysphagia is meaning that number needed to treat will be 3, but they will have a high risk of dysphagia, and number needed to treat is low. Number needed to treat meaning that how many patients you will treat to have a certain amount of improvement in at least one of them. So if you want to see 20% improvement, you inject 2 patients, at least one will have 20% improvement. If you want to have significant improvement, let's say 1 out of 3 patients should have improvement, then you need 10,000 units, but then dry mouth is more common. But here, one impression you may be getting is that somehow dose is the main reason behind improvement. You saw in the previous slide and in the current slide that the higher dose you use, more the side effects, but then more common is the improvement or the amount of improvement is more. But I think that's that although in general is true, is not the complete story. The improvement also depends on the right selection of muscle and the right distribution or spread of the dose among different muscles. So it's not always the same. Two injectors may not exactly be the same. On a botulinum toxin A or Botox, the most commonly used drug, the trial had 120 and 150 unit of mean dose, range of 70 to 250 unit, although that still is on the low side. In my experience, most patients require 250 units or higher. Very few patients end up between 150 to 250 units. Almost nobody below 150 unit for botulinum Botox injection. 61% improvement was noted. Dysphagia was 19%, so 1 in 5, which is much lower compared to 48% in type B toxin study, or myoblock, which is almost like 1 in 2 patients. And then finally, Xeomin, there was a study using 120 and 240 unit, and it showed twisters improvement of 7.5 to 10 with 120 dose and 9 to 11 with 240 dose. So definitely higher dose can provide more benefit, but remember the dosing distribution and the patient examination, muscle selection also have significant role to play. So what are the challenges when you are doing cervical dystonia injections for botulinum toxin? Muscles selection in these studies was at the discretion of injectors. So they were not standardized in selections. Each injector could decide what muscle they want to inject. EMG use was also at discretion of investigator or was just completely excluded. So all these old trials were done either with no EMG guidance or only partial EMG guidance in some patients. It is unclear that dose selection in comparison trials, how that was done, and the outcome measures that were being used were also variable. Although I mostly reported twisters, some of these trials were using SUI rating scale or global impression of change or percent responders, as I showed, and number needed to treat with more than 20% response, more than 30% response as some of the outcome measures. So that's why these trials are not very comparable. And then unfortunately, there is no way around the debate of muscle selection in EMG because there is no standard muscle paradigm that you can use, unlike some other indications. All right, so when you are seeing a patient for cervical dystonia in your Botox clinic, these are the 6 steps that you need to follow to successfully complete a good chemodenervation. You need to make sure that you have the right diagnosis about dystonia and cervical dystonia. You have to have a good analysis of abnormal movements to figure out which muscles are involved based on that movement and what would be needed to be injected to improve it. You need to then make the right dosing, which of course comes with training and practice. And then you have to do the injections properly so that you inject the drug right. And then you have to adopt the therapy to the initial response of the patient after the first 1 and 2 sessions. All right, so here is an example of a challenge for diagnosis of a dystonia. This clearly is not cervical dystonia, it's a foot dystonia. And you're seeing some fixed posture abnormalities with the foot plantar flexed in both sides and inverted in this patient. And the point of showing this video is that, as you can see, the foot dystonia remains the same or fixed. And in this patient, the dystonia does not go away even in his sleep. Now, if you have a fixed posture abnormality, you want to make sure it's not spasticity or spastic dystonia. But if it is true dystonia without spasticity, then it should not be fixed. A fixed dystonia is psychogenic until proven otherwise. So it's very counterintuitive, but very important information. That's just one of the challenges of making diagnosis. So you don't, as I mentioned, one of the challenge earlier, that in Parkinson's, when you have head drop or enterocollis, it's not always that they have a dystonia. They may have no dystonia, or they may have some mild dystonia, but they may have extensor neck weakness as the main problem and presenting as enterocollis, which you may think as dystonia. So diagnosis is not always easy and straightforward. All right, muscle selection, as I mentioned earlier, and then the proper diagnosis of the movement, which is then followed by the right muscle selection, is very important because there are multiple muscles, I believe more than 20 muscles on each side of the neck that you can inject, and even more that we don't or inject or are not able to easily inject, because there are 3 layers of muscles in the neck that you are injecting and you're going through them. So proper analysis of the head movement is the first step to leading to the right muscle selection. So let's start with analysis. So let's start with the analysis of the head movements, and then we will go over to the muscle selection. These are the 4 primary movements of the head. So enterocollis, anterior and posterior, which is in one plane. Then you have the laterocollis, which is in second plane. And then you have the torticollis, which is in the third plane of movement. And you can have a combination of the 2. You can have combination of 3. So a patient may have an enterocollis, they may have a torticollis, and then they may have a laterocollis along with it, and giving them an unusually twisted head movement. And as I mentioned earlier, dystonia is variable. It can come and go or fluctuate. So you may have challenge trying to figure out, do they have enterocollis with torticollis or not? Do they have laterocollis or not? And you have to do a detailed assessment to try to make your final assessment, which one do they have. One thing that further complicates the whole situation is the compensation. Someone who has a lot of posterior and have trouble with their head pulled back, they sometimes compensate by keeping head tucked down, and they may be sitting like this as if they have enterocollis, but what they're trying to do is to compensate for posterior. And what happens is that as you distract them during examination, during walking, during various maneuvers, you may see the posterior show up. And if the posterior show up during distraction, then that has to be the primary movement, and enterocollis cannot coexist with posterior. That must have been a compensation. Just to give an example. There are many such examples. This is not an exclusionary list. So these are the movements I mentioned earlier: laterocollis, torticollis, posterior, enterocollis. So let's look at some of the examination of patients with these movements. And here is a patient with an enterocollis. You may not be even able to pick up an enterocollis when you're looking at the patient from the front. You may now see it because I said so. Even without me saying it, it may not have been obvious. So the best way to assess an enterocollis is to look at the patient from the side, to look at the space between the chin and the chest. Even now, if you look at my chin and the chest, and then look at her chin and the chest, you can see that her chin is much closer to the chest than mine is when looking straight ahead. But when you look at the side, it becomes much more obvious. The head is being tilted down. You can look at the plane of the head at the eye level. You can look at the jaw level, or you can just look at the space between the chin and the chest in various ways. A normal person should have at least a fist amount of space between the chin and the chest. You should be able to push your fist in very easily between those two. But you can also look at the plane of the level of the eyes, and being tilted down and up can give you an idea of an enterocollis or posterior, same reasons. All right, here is the examination. We're looking at the patient from the front. Patient was asked to relax and look straight. And again, from the side, it's much more easy and
very good.
Obvious.
You can open your eyes.
Very
good. And I'm going to just check your neck again. Okay. So look all the way up to the ceiling. Go all the way up.
So you're looking for the range of movement to see how far she can go up, and you're looking for any muscle spasm. Normally, the muscles or SCM should not be spasmodic. When someone is looking up, they should relax. But if they are contracting, looking up, then they are dystonic. And looking all the way down, all the way range
up, all the way to the right,
to see how far they can go, all the way to the right. And SCM now may fight. So one SCM should be active when looking to the other side, but the other SCM should relax. And if it's not relaxing,
all the way to the left,
that is co-contraction and also an evidence for cervical dystonia.
Very good. Now all the way straight. Good. Very good. Okay.
All right. So enterocollis, the most common muscle involved in enterocollis is sternocleidomastoid. Some other muscles can also be involved. The most common way the head comes down is actually gravity. The head is heavy and the head can be just pulled down by gravity. So someone can have an enterocollis just because of the weakness of the extensor muscles, like in Parkinson's patient, especially in pure enterocollis without any other twist involved. The other muscles that can pull the head down will include the platysma. So the platysma muscle, if it's really tight and active, can really pull the head down. The digastric muscle in the front can pull not only the jaw down, but can also pull the head down secondarily. And then there is some mild weak enterocollis effect of scalene muscle, especially anterior scalene, but it's not clinically very effective. It's not a muscle we typically inject because of its deep location next to carotid. So SCM will be the main muscle to inject, and you may inject platysma if there's obviously involved. I usually do not inject digastric until I have a clear reason for. Typical starting dose for Botox is 10 to 40 units in a sternocleidomastoid spread in 1 to 2 injections. The dilution is usually 1 ml. I don't dilute it too much because SCM is a thin muscle and the drug can go too deep if you give too much volume. And later on, in a stable setting, usually sternocleidomastoid requires 50 to 150 units of injection on each muscle spread in 1 to 4 sites, and I stick with 1 cc dilution. I typically use the 27 gauge needle. There is even a 30 gauge needle available if you are doing without EMG guidance. For EMG guidance, 27 gauge is the thinnest gauge that I know of. I typically use 1.5 millimeter injection needle. You can also use 1 1/4, even 1 inch will be okay if you're doing based on anatomy guidance.
Turn your head that way.
Here is a technique.
Very good. Now put your left hand against your chin. Very good. Now push your hand against yourself. Try to look that way and push your hand this way. Very good. And there's a poke. All right. Done. How was that?
Tolerable.
All right, postrocollis. Postrocollis is pulling of the head backwards. A pure postrocollis without any other twist involvement, without torticollis or laterocollis, is tardive until proven otherwise. So tardive dystonia classically give you postrocollis. The other classic association of postrocollis in Parkinson's patient is PSP, progressive supranuclear palsy, classically give you postrocollis, while the Parkinson's disease classically give you enterocollis. And those are some tips to remember. The typical anatomy of muscles involved are the most strongest muscle will be the one in the center, parallel to the center, and that one will be longissimus capitis, not shown in the image here. Longissimus capitis is the strongest and most powerful postrocolic muscle, and that muscle, if you weaken too much, can actually cause head drop because of the need for keeping head up stable, and natural tilt of the head is downward always. It's always falling downward, and the longissimus is always working some. But there are many muscles that are also involved in lifting the head up as their secondary function. So splenius capitis and semispinalis capitis, and even weakly splenius cervicis, which we typically don't inject, and levator scapulae that we typically do inject, but is not specifically for postrocollis as much. So main injection for postrocollis will be longissimus capitis. Trapezius also has a role not shown in this on the surface, and then secondarily or weakly splenius and semispinalis capitis. If pure postrocollis, I may just start with trapezius and longissimus capitis, and that's it, and see how patient do. This is injection for splenius capitis, typically in the groove between trapezius and SCM, directed towards the other ear, tragus of the other ear. The first layer usually is splenius capitis because you are lateral to the trapezius. Unless you are too medial, then you will be going through trapezius. And then the second muscle deeper to splenius, to this first one is splenius, and then if you keep going in, then the second muscle that you hear will be semispinalis. This is a static because of poor grounding. Very common in EMG when you're doing, especially with the handheld machine, which is a more simplified machine. Now I'm doing her levator, longissimus capitis, which is a spinal muscle. I'm trying to go high in the upper one third or posterolateral. Very active oscillate rest in general, even without dystonia. And I use low dose, typically 5 units. Although if you go deeper, you can still hit longissimus. Although now if you lateral here, this may be just a trapezius injection. It was not too good. And if I revolve a trapezius, there is some debate on trapezius having two different direction fibers. So the more central, medial, vertical fibers of trapezius, like this one, are the one involved with the posterolateral, while the lateral shoulder muscles are more involved in shoulder elevation, tilting of the head laterally and not posterolaterally. Alright, sorry it was too loud and noisy, but I left the sound in for you to listen to EMG. Alright, so typical starting doses for me for longissimus is typically 5 to 10 units, usually not 30. 30 will be a big dose in longissimus. Splenius and semispinalis is typically starting dose is 15 to 20 units. And then you can see later on, often the dose required is much higher. And then you start adding a more site if you're going above 15-20 units of an injection. Again, I stick with 1 cc dilution. I do not do 2 to 4 cc dilution. These are thin muscles. And then I stick with 27 gauge for EMG guidance or 30 gauge for anatomical injections and 1.5 inch or 1.25 inch long needle. Laterocollis is pulling or tilting to the side, unlike the enteroposterocollis or torticollis. And we will look at how it looks like and what muscles are involved next.
All right. Right, now try to raise your head up as much as you can. Do your best. Very good. And can you straighten it anymore?
Straighten it anymore? Well, I don't really know what straight is.
Okay. Can you look all the way up to the ceiling?
No.
Okay. And look down to the floor. Okay. Now try to look to the left. Okay, and just relax and let it go where it wants to go.
All right, so the muscles involved in laterocollis, the most strongest muscle for laterocollis is levator scapulae, runs from the side of the neck down to the apex of the scapula, pulls both towards each other, so the head goes down and the shoulder comes up, or scapula comes up. And then the other muscles that have some weak laterocollis will include the splenius and semispinalis capitis, usually splenius more so than semispinalis. You can have some laterocollis also from trapezius, especially the lateral fibers, and then even longissimus have some laterocollis action, but not very strong, especially if there is no posterocollis involved. These are my starting doses. So levator scapulae, typically I go high, 10, 15 units at least, maybe even 20. And usually I skip longissimus if there is no posterocollis. Splenius and semispinalis will also be 10-15 units or so. Scalene, I will usually inject scalenus medius for electrocollis, especially if I can palpate it, if it's involved and spasmodic. And then you can see the higher doses later on. Again, 1 cc dilution only, 27 gauge, 1.5 inch. If I'm giving more than 15 or 20 units, I will do more than one site.
Tighten up your SCM.
It's really tight. Can we go that level?
Earlobe, yeah. Right here. Alright, here's a poke.
Sternocleidomastoid, I didn't mention that in the previous slide. Sternocleidomastoid is also very strongly electrocollis, especially if only one of the SCM is involved. If both are involved, there is usually no electrocollis and it's just intracollis. But if one is only involved or significantly more involved, electrocollis from that.
One level
That was
lower.
SCM. Just doing multiple shots.
Okay, here's a poke.
You can hear the EMG a little bit. The static goes away.
These are high injections, but if you're worried about swallowing, you will avoid that. The best is to have the needle approach as high up as you can.
Okay.
Slant it, so to push it, the drug away into the muscle, but away from the swallowing muscles. These are high injections. Okay, so this is the posterior. This here is posterior. So let's listen to it 10 times to 1.
This angle.
Yeah.
If you do injections in the lower half of SCM, there's a risk of dysphagia is high. Now
Yeah,
she's
10 times
injecting
1 is
scalenus
fine.
medius muscle, and this is just behind the
Okay.
SCM. You can
Now
actually
let's
see
try
it.
a bit later. So this is the trapezius cord. It should be behind this cord,
The
but
rubbery
right at this angle.
Okay. So go
So
through
it's
that cord.
parallel, exactly, through that cord,
And
you know, horizontal to her shoulder.
Now she's going for the levator scapulae. Levator
Horizontal?
scapulae
No.
is horizontal,
Like
parallel
this.
to the
Okay.
ground, and then slightly angled in, right through the anterior edge of the trapezius.
This one.
I
So this
usually
is too deep
feel
to
the
be
levator
levator,
scapulae
right?
first.
So this is
with my
too deep to be
finger in
To be
trapezius. So this is
trapezius, so that is
levator.
levator.
So let's she's loud.
Involved levator
Let's give her
scapulae,
15,
spasmodic levator
20 units there.
scapulae is very easily palpable beneath the trapezius.
Okay.
So
Okay.
it's deep
And let's
muscle.
check this please. Yeah, so go in the middle and then so beyond the trapezius margin and then towards her other ear.
Splenius capitis involvement again can happen with electrocollis.
Go a little deeper.
Especially if the
Yeah,
patient
it's
has
active.
electrocollis.
So let's give her 10 times
Or
1.
So she's adding a little bit of splenius
And you want
capitis.
semispinalis at all?
Yeah, and let's check it.
And
It's
then
also
she's gonna go
active.
deep
Let's give her 10
to check
times
the
1.
semispinalis to see if that is involved. If it is, then I will add a little bit.
Okay. Alright, well.
Okay. All right, so torticollis is the rotation of the head. Again, the main muscle that rotate the head is the sternocleidomastoid. Primary function is rotation of the head to the opposite side, although it has some slight electrocollis, and when both of them are involved also can cause electrocollis. Other muscles that rotate will be splenius capitis and semispinalis capitis. Others usually are weak or not easily injectable, so I don't typically inject splenius cervicis. And then levator scapulae usually is not involved unless there is electrocollis or shoulder elevation involved with it, or sometimes pain will be a reason for me to inject levator scapulae. Pain in cervical dystonia is the only dystonia that has it. 2/3 of the patient have pain. There are 3 muscles that are the most common sources of pain. The one is trapezius, which is most common. Second most common is levator scapulae, and the third most common is the transverse oblique muscle up high in the neck. And that is usually also very significantly involved in the side-to-side tremor of cervical dystonia. All right, here's a patient with torticollis. Let's look at the examination. Even on the still image, if you look at at his head and neck, you see some observation. The right shoulder is slightly higher than the left. You can see that the right ear is lower, closer to the shoulder as compared to the left. And you can also see that the right ear is slightly better visible than the left, at least in this image. But let's see what the video shows.
It's the right side shoulder elevation.
Okay.
And keep your eyes closed and start from 20 and count backwards by taking away 3s.
The tilting of the head.
20, 17,
This is just
14,
to distract him so that he doesn't focus
11,
on neutralizing his head position.
8,
You can see increasing left torticollis, so the
5,
left ear becoming less visible, and the right ear is becoming more visible as
2.
he's
Good.
counting.
Keep your eyes
There's also
closed.
slight right lateral collis and the right shoulder elevation. There doesn't seem to be any obvious anteropostrocollis so far, but looking from the side, we can actually see slight postrocollis. The head is slightly pulled back up and chin is slightly
Very
down
good.
a little bit. So slight postrocollis, slight right lateral collis, slight left torticollis.
Okay, here's a
Here is
poke.
the injection technique. Let's play the video. So I'm
And
injecting the
there's
splenius capitis.
Not
I'm
very
going
loud
lateral to
on
the
our
trapezius
machine
edge. So the
here.
first muscle I should hear should be
So
splenius.
it's
I will
15
give a little
minutes
bit of injection there,
on
and then
splenius.
I may go deeper to look
And
at the
then we'll go to
semispinalis.
Semispinalis. So it's more active again. She is not picking it up.
Get
Right,
the
so 20
exertional
minutes
activity of
time
semispinalis.
zone on that.
Non-significant
Semispinalis.
right now.
And then we are doing the right levator. Increase the volume of the machine.
Levator scapula.
Then we do the right levator, 15 minutes time 1. The inferior border of trapezius. So,
Feeling the trapezius edge, going through the trapezius edge, parallel to the ground.
And here's the levator. The first sound was trapezius. We skip that. And the levator is 15 times 1, so very active.
How active the levator is.
Alright, and then we're doing trapezius 5 times 4. 4.
Trapezius 5 times 4.
And 4.
Usually this levator goes only with the pain, not specifically for its involvement in terms of
Very good.
bulky
Done with this side.
If trapezius is dystonic and causing posture, this will not be enough of a dose. But for pain, this will be enough. All right. Starting doses is again here for torticollis, it's either SCM or splenius capitis. For a splenius capitis, if it's dystonic, the starting dose typically is around 30 units or 45. If SCM is primarily dystonic torticollis, then it's typically 30 to 60 units of a starting dose, and then everything else. You can see there, dilution will 1 ml in 27 gauge, 1.5 inch needle. All right. So coming to the response to the injections, after you have done the injections, remember the black box warning on all botulinum toxin injections that the drug can spread diffusely through the blood supply and can cause a mild form of botulism, causing swallowing difficulty and breathing difficulty. If very high doses, it can be life-threatening. Usually in the clinical doses that we use, it's not any significant weakness. There may be some mild swallowing difficulty, but even then they are able to eat and doesn't always require a tube placement. If they're not very bad, they can just stay at home and watch. If they are feeling bad, they can come to the hospital for a few days. If you get injection benefit for the first couple of times, but then you do third time, fourth time, and the injections go away, that may be that now they have developed immune resistance. We don't see it very often anymore. It's less than 0.1% or less than 1 in 1,000 patients. Injections, it is more frequent when there is more frequent injections, more, every few weeks or so, or a booster injection at 1 to 2 weeks after first injection. And then sometime there is some relationship with the protein content of the toxin itself. So maybe more common with dirty drugs like Dysport or Botox, less so with Xeomin. The common side effects in the clinical studies were dysphagia in 19 to 30% of the patient, type B toxin at 30%, type A toxin typically around 19% in the trial. Within trial, the doses were being used high. You can also inject the SCM higher, so make it less likely. You can also stay with 1 cc dilution so it doesn't spread too much. In my patient, the dysphagia is almost never more than 1 to 2%. Patients were noted to have more often upper respiratory tract infections. Neck pain from the injection itself can be seen, although in the long run, neck pain gets better with the injection, with the muscle spasm loosening up. But initially, especially with the first injection, when the muscles are very tight and spasmodic, you do the injection and it causes significant local site pain that can last for a few days. Headaches can be triggered by the injection itself, and then back injection can cause head drop because of excessive weakness. The trick here is to not give too much of a dose in longissimus capitis. Don't give high injection in longissimus. The higher the injection, the more effective it is, mechanically speaking, for causing the head drop. The lower the injection in longissimus, the less effective it is with the same dose. So if you give 5 unit lower here, much less effective. You give 5 unit up here, much more effective, much more powerful. Again, I don't see head drop in more than a couple of % of my patients. So I don't have side effects in more than 5% of my patients, even with repeated injections. Actually, even not even 5%. I would say 1% of all sessions that I do will have some mild side effect, usually just brought up by the patient, but not bothersome to them. They don't stop getting injections for those side effects. If you do not get good response after your first session, revisit the diagnosis, make sure you have the right diagnosis, review your muscle selection, especially based on patient response. If everything looks fine, then just gradually increase the dose. The dose may not have been high enough, especially if there was no side effect. If there was side effect, or if any movement got worse, then you definitely want to change your muscle selection. And then try to quantify the response with the rating scale, either with SWE or twisters, or make some videos to see what there are, because patient may say they have not responded when you can see a response. And then there is a chance of about 15% of primary non-responders. So that's not immune resistance. Immune resistance is secondary non-responders. A person who never responded cannot be called to have an immune resistance, and that despite your best effort for muscle selection and diagnosis and dosing and everything, if the patient is not responding even after 2 or 3 sessions, then that's a primary non-responders, and the chance of that is about 1 in 7 or 15% or so. Thank you so much for your attention. I hope you enjoyed listening to this, and I'm looking forward to working with you guys during the workshop.